Is your practice tired of wrestling with insurance denials, deciphering EOBs, and watching your revenue slip through the cracks? You are not alone. Welcome to The Claim Game, the podcast designed to cut through the confusion and provide you with the best practices for revenue cycle management success. We are Jeremy and Catherine Zug, and we've been with people just like you in the trenches. Each week, we'll break down complex billing processes, share real-world solutions from practices like yours, and ask questions of the game makers and changers of healthcare so you can take control of your revenue. Let's turn those claim denials into deposits and help you return to focusing on patient care. It's time to win the claim game.
Welcome back to the Claim Game podcast. As a reminder, every so often we like to take a strategic pause to get a behind-the-scenes look at the very board, the game that we're playing, and talk to the game designers. Think of these episodes as consulting the game makers or game changers themselves, the architects and the folks that build the board that we play on. And these special rounds, these special episodes offer invaluable insights into the design and development of the healthcare landscape. By interviewing these folks, we get a deeper understanding of the rules and nuances of the board. And this knowledge will give you a significant advantage, allowing you to navigate the terrain with much greater clarity and to make more informed decisions as you grow your practice. So get ready to learn directly from the game makers and enhance your understanding of the claim game. Today's game maker is Dr. Dylan Ross. He's a nationally recognized leader in behavioral health care, clinical innovation, and measurement-based care. Dr. Ross is an organizational psychologist and a dual licensed behavioral health clinician with a distinguished career driving clinical strategy and digital transformation at major healthcare organizations. Dr. Ross currently serves as the head of clinical at Blueprint, the nation's industry-leading AI-driven clinician enablement platform, where he leads efforts to design and scale provider solutions that enhance care delivery and provider efficiency. Prior to Blueprint, he served as the Vice President of Clinical Innovation at Rogers Behavioral Health, where he led system-level digital innovation. As National Senior Director of Clinical Strategy at Optum United Health Group, he developed and implemented an enterprise-wide measurement-informed care framework that underpins Optum's value-based care strategy today. Early in his career, Dr. Ross held several leadership roles at Kaiser Permanente, including KP Colorado, the Permanente Medical Group in Northern California, and the Care Management Institute at National Program Offices, where he oversaw behavioral health quality for the health plan, led initiatives integrating behavioral health further upstream into primary care, and oversaw clinical operations for substance use disorder treatment and recovery services for the Colorado market. Dr. Ross currently chairs the American Psychological Association's National Advisory Committee for measurement-based care, guiding national strategy to advance standardized clinical measurement protocols across the behavioral health sector. With a career dedicated to advancing clinical excellence, data-driven care, and value-based innovation, Dr. Ross is a trusted voice in the transformation of behavioral healthcare. Please welcome Dr. Dylan Ross. All right, Dylan, thanks for being on the Claim Game podcast. We really appreciate you being here.
You bet, Jeremy. Excited to join.
Yeah, amazing. We got introduced at Meet You in Kentucky, so shout out to Casey there, and it was really great meeting you. Can you take us back through your career? Before you got into tech and the insurance world, you started out as a clinical psychologist. Roll the tape back with us. What got you interested in clinical work to begin with?
Yeah, so maybe by way of intro, I'm an organizational psychologist, licensed psychotherapist. So PhD, org psych, and then at the master's level, a licensed professional clinical counselor and MFT, respectfully. But yeah, I joke about coming into managed healthcare through the back door. Was actually working for Outward Bound and working with kiddos outside in a wilderness context for many years. Would lead month-long expeditions in Florida, Georgia, South Carolina, Alabama, through the Sierras, the Cascades, and the like. And what I found was that the intervention in terms of the wilderness experience, while powerful, when the kids would return home to the same family system, to the same neighborhood, to the same schools, to the same peer group, oftentimes there was a regression in terms of behaviors, as well as a lot of the problems that ultimately led to them going on a whatever month-long canoe trip with me. And in retrospect, I was likely ill prepared as a 20 something to go in and, work with families in the way that we were. But it was enlightening in terms of opening the door to the work that at the time I really saw where the value was working at a systems level with families. So that was my impetus to go back and get clinical training. And to be really frank, most of healthcare, or behavioral healthcare specifically, the unfortunate reality is those with the highest level of needs in terms of clinical complexity, lacking privilege to access, oftentimes without having the appropriate means to pay for the care that's needed. Most of that care is delivered on the backs of those that are least prepared in terms of newer career providers. And so post-masters, post-doctorate, and while there's some, paid internships or other types of opportunities for practice as you're earning your hours towards licensure, when I found myself, post-masters, had degree in hand and needed to get those 3,000 clinically supervised hours, it was really hard to find frankly, a paying internship. And so as I was leading, you're asking, I may go long here, Jeremy, but I was leading a pack trip on horses from the west side of the Cascades to the east in Oregon, and had an interview scheduled with a substance use disorder treatment program for adolescents for Kaiser Permanente in San Francisco. I was earning $110 a day as a wilderness therapist type. And they offered a $20 per hour opportunity in terms of training, which was $20 more than all the other kind of offers that were out there. And so, long story short, was taking a satellite phone call from the top of a peak, and every 6 minutes would lose connection as satellites would move. This is back in the day when connection wasn't what it was, but the hiring manager was a RAF guide. Dean Blumberg, wonderful guy. And he thought what I was doing was just so cool. And he took a gamble on, this ragtag kid that was interested in figuring out how to work with addiction, which was a known gap in terms of my training. And given the population I was working with, it was an area I really wanted to kind of strengthen clinically. So fast forward, entered into an integrated health system, Kaiser Permanente, 12.5 million covered lives across 8 different markets or regions, maybe 10 states if memory serves, and came in and started cutting my teeth in terms of working with substance use disorder treatment with a focus on adolescents and families. And I just fell in love with the work. And so did that for, direct care for 6, 7, 8 years. But in the lead up to the Affordable Care Act, there was a lot of conversation around how policy and kind of more structural issues were shaping how healthcare in general was working or not in America. And as I had the privilege of working for a very unique system in that, Kaiser Permanente is both the care delivery kind of organization, but also their own insurance company. The incentives out the gate were much better aligned. At the same time, saw tremendous challenges in terms of communication, coordination, integration, within and between subspecialties. And given the fact that, up until, not too long ago, most of the healthcare system really kind of took the head off the body and siloed it in terms of where care should be received. And what Kaiser was hoping to do was to change that and to move further upstream, bringing in innovative integrated care models, collaborative care. And I just fell in love with the opportunity in terms of what that could do, first for Kaiser, but broadly for care in America. So decided to go back and get a PhD. Was surprised as I went through that how much overlap there was in terms of the clinical underpinnings of many of the theoretical models of organizational psychology, looking at some of the the big names in terms of the big thinkers in the IO space, institutional and organizational psychology space, most came in from clinical backgrounds, and that was really kind of shown in terms of a lot of the models I was learning. So after close to 8 years of delivering direct care for Kaiser Permanente, moved to a national role at Kaiser and had the opportunity to work as an internal consultant in an incubator called the Care Management Institute. And we had a number of different charges. One was to help prepare the organization to more reliably attain quality aims when it came to HEDIS, Medicare 5-star, but just general quality when it came to access and other things within behavioral health. And the other charge was to be the kind of heads up, horizon focused group within Kaiser, learning from other health systems. And so we had a learning collaborative set up with the National Health System in the UK, the Veterans Administration, the Department of Defense, and VA and DoD in particular often get a bad rap when we look to how government at times can fall short in terms of what our hopes might be. At the same time, they were so much further ahead in terms of integration. And so we held summits in DC with representatives of both DoD and VA, spent an inordinate amount of time learning about the improving access to psychological therapies, IAP model in the National Health Service as they kind of scaled their stepped care models, bringing standardized behavioral health screening into primary care settings, and creating a system of care truly, which frankly is lacking when we think about behavioral health care broadly in America. And so it was just such a phenomenal learning opportunity for me. As I went deeper into the quality space, an opportunity came up to pivot to oversee behavioral health quality for the health plan in Colorado. And so that was kind of shifting from care delivery and innovation and kind of big quality to formal quality in a health plan setting.
Wow. Yeah. So you're in the major payers and I totally get your perspective on the back door, right? Because you're trying to improve access to care and that leaves you up this route. And so to round out your story, so you're at the payers, but now you're at Blueprint, and we'll get to Blueprint in a minute, but how did you go from care delivery to payers to Blueprint?
Yeah. So, the other job, as you stay longer at Kaiser, but this is probably true with other large organizations, your email signature gets longer as your scope of responsibility and accountability grows. And so while also, having the day job of overseeing behavioral health quality for the health plan in Colorado for Kaiser, was also overseeing clinical operations and expansion for the substance use disorder treatment operations for the market. And at the peak of the opioid epidemic, we had inexcusable long wait lists in terms of getting patients in and members in from the health plan perspective, but getting patients in to initiate treatment for opioid use disorder along with other addictions. And so we decided to blow the model up, and it was a wild success. We moved to an urgent care model, called it Rapid Start. We moved to a team-based care model, which footnote at this point, but that was my dissertation, building high reliability kind of team training models and kind of systems of care with various subspecialty providers, bringing them together. But long story short, we went from a multi-week, at times, month plus wait list to same day, next day access. While I was good at the trains on time in terms of operations, which is often, the mechanics of care, the direction and future that Kaiser saw me as an up and coming leader was going to be more and more of that. And I just knew my heart wasn't necessarily there. And so one of my prior leaders that is both a mentor to me and has done some wonderful work in his career, Andrew Bertagnoli, had left Kaiser. He's now oversees behavioral health for One Medical, but had gone to Optum, and he was building a clinical product function with Optum Behavioral Health. And the more I learned about what he was doing, an opportunity came up, and as opposed to going down the rabbit hole of operations at Kaiser, made the jump from Kaiser to Optum. That was a steep learning curve. And while I love all that Kaiser does, some perspectives in retrospect is that they often promote clinical leaders into business functional roles roles. And, that Peter principle at times, the result was you'd have, 80% of executive leadership that were clinical by background really didn't have the acumen at times to really, I think, execute in the way that was needed in a very competitive marketplace, especially post ACA. We had exchanges now, this kind of new benefit design in terms of high deductible plans, and the competition on the health plan side in terms of benefits was heating up. And so going from that to Optum, which I guess I would say is kind of the inverse, pedigree MBAs from, top tier schools running, which is a pretty impressive operation at Optum. I really understood and learned quickly how effective business operations run at a health plan. So what we were doing in the clinical product capacity was pretty interesting. We had the charge to ultimately co-design with large employers, custom white glove solutions, whether it be the Apples and the Targets of the like. They'd come in with a focused problem, and we would build programs, in essence, products that would help be positioned to address those needs. But we also did a whole host of other things. So a rewrite of the algorithms that run on the 50 million behavioral health specific covered lives. There was over 500,000 behavioral health clinicians. So the size and scale of what Optum does is really notable. And so there was a couple of business moves within that, but found myself reporting to the chief medical officer, Martin Rosenzweig, wonderful leader. And my kind of portfolio work at the time quickly was rounded out with leading strategy design for measurement-based care, or now kindly referred within their organization as measurement-informed care, to really set the organization up to take steps forward on value-based care or bring alternative payment models to bear. And so did that for close to 4 years. And, I guess to make the longer intro longer, really missed care delivery, and I'd set up a learning collaborative with a subspecialty hospital system based out of the Midwest called Rogers Behavioral. And so on the Optum side, we were bringing pharmacy, behavioral, and medical claims to the table. Rogers had over 25 years of patient-reported outcome data. The problem that we're trying to really learn and understand was kind of, in particular to Medicaid within the state of Wisconsin, what was accounting for really differentiated outcomes in terms of both clinical outcomes, but also a decrease in readmission rates, and pretty much any of the outcomes that you would stack next to Rogers Behavioral Health was just outperforming all other players within a similar market. And so by commingling these different data sets, we can interrogate the data to really understand what was accounting for these exceptional outcomes. And the more I learned about Rogers, the more I just kind of fell head over heels. 118-year-old nonprofit, privately held health hospital system, 3 inpatient hospitals, maybe they're up to 17, I think, residential treatment programs, 23 outpatient locations servicing IOP, PHP, residential and inpatient across 10 states. But what they had built over the past 10 years, as I was engaging with them, they brought in a lean Six Sigma way of working. And they had really matured forward both clinical but also administrative functions, and we're running, as they call them, rapid improvement events. So these would be 4-day deep dives into a clinical, operational, or more service-oriented challenge, and would bring representative functional leaders, family members, patients alike that had graduated from the program into a kind of a participatory solution design process. And so they ran over 90 of these events per year, and was floored at how they had, again, to come back to one of the themes that I was just intrigued by, they were delivering high reliability outcomes. And I had never seen anything like it. What was the secret sauce, as I learned more, was standardized treatment protocols. So having very clear guidance in terms of the kind of treatment input. They were able to remove a lot of the, dare I say, unwarranted variation that is the 1,000 blooming flowers of how most behavioral health practitioners practice. There's a lot of idiosyncratic practices. While most will endorse using evidence-based care, the reality is the adherence to such protocols, which really inform and underpin such evidence-based care delivery models, is just to say fidelity is not where it should be. And so that was notable. The second, measurement-based care outcomes really were guiding much of the work. You knew when you're treating to target if you were on the mark or off the mark, which using data as an early signal within the care process could account for earlier treatment adjustments, which really helps with downstream clinical outcomes. Again, the lean model and Six Sigma in terms of really bringing in data, bringing in an innovative way of co-design through their improvement process. And so all of these things were really leading to what I was just floored by. And I guess just to kind of give an example, as I learned more about Rogers, they have a BI platform and they've got a battery of assessments that they administer. Each battery, depending on clinical diagnosis and clinical program, you have what they called a main measure. So this would be like the leading indicator of whether treatment was working or not from a clinical standpoint. And so they pulled up their Power BI and showed, YBox, which is a clinical assessment tool focused on OCD. And they had ultimately achieved statistically insignificant differences in terms of treatment outcomes, all showing clinically significant change over the course of treatment by way of reduction of YBox scores from treatment start to treatment end. And looking across all their sites, I had never seen anything like that. And so coming from my Kaiser days with some of the most powerful and robust population health models, advanced analytics really guiding a lot of that, even with other chronic health conditions, let alone behavioral health, coming to Rogers was really impressive. So I left Optum and joined as a vice president of clinical innovations and digital strategy at the peak of COVID, trying to bring in novel technology to really enhance care outcomes, but also the experience of care. So did that for about 2 years, went out and did some consulting with an AI-driven technology company, with a clinical content group and lots of other startups, and also chair the American Psychological Association's National Advisory Committee for Measurement-Based Care. And now I can get to my blueprint. And in that capacity, met Danny Freed, our CEO and founder of Blueprint, and about a year and a half ago, assumed the role of head of clinical here.
There you go. Your toolbox is huge. I mean, you've essentially had this, like every experience you've had has added a new thing to the box, right? And people can say what they want about Optum, but they know how to run an organization, right? And so you've just been able to acquire all these skills from some really high quality leaders, it sounds like.
It's true. I wish I could claim it to be, a personal strategy with lots of intention behind it, but it was a bit more organic than that. And, opportunities and timing at times kind of, inform if you take the left versus the right in life. And a lot of these opportunities kind of came at the right time. But to your point, I haven't met many others with a similar kind of professional profile. And I can name, a handful of the kind of key learnings from every context. But to be able to approach behavioral health today with clear understanding and to be able to represent the perspective and interests of payers, integrated health systems, behavioral health providers across every segment, technology, but also kind of bring in the kind of academic rigor of what the APA does. It's really been a phenomenal foundation for me in terms of my work today and frankly beyond.
Yeah, I praise God for that satellite call, man. I'm glad that thing didn't cut out on you.
I mean, I joke about, again, back to the take the left versus the right. Sometimes in life, we don't know when those really momentous decisions are upon us. It just seems like you're making the next right one. But in retrospect, it's kind of knitted together to be a wonderful career so far.
Oh, that's wonderful. Yeah, so I have a couple questions, but go back to your experience working at the major insurance companies that you've worked at. What was some of maybe the biggest, most surprising reality check for you? You walk in, you have an expectation that it's going to work a certain way, and then there's a sharp reality check. What would that be, or what would you describe as some of the most surprising reality checks you saw there?
Yeah, I mean, to Optum and Kaiser for that matter's credit, because health plans, insurance companies, payers often get a bad rap. I remain deeply touched by the level of commitment at the individual kind of leader level in terms of what each person is trying to do. And, the collection of activities and decisions in any organization, when taken in aggregate, lead to kind of how that organization performs as a whole. But I was really struck by the level of commitment and integrity of the leaders that were trying to really do the best thing. At Optum, again, United Health Group, public enemy number one at times out there in the press. I got to say that there's wonderful people that are really mission driven, that are heads down trying to improve care from where they sit within the organization. And so I do think it's important to note that. That said, if you look at an insurance company, it has two main objectives, whether you're public or private. Number one, it's trying to make money. And so whether that's the growth motion, really trying to build benefits and products, offerings that align to what the leading demand is, chiefly in the kind of employer sector, but also looking to other private and insurance offerings. And so the way that the employers go, especially in the commercial market, is the direction that from that growth angle, payers move in from a commercial strategy standpoint. The second is that they, in order to really preserve and achieve commercial success, there is incentives built in. I know this won't shock anybody that may be listening to this, to spend less. And so managing those benefits is obviously within a managed care setting, or just insurance in general. And spending less is there's strong incentives behind that. And so where you find conflict, of course, is when you've got a population of members, consumers that really have, back to behavioral health, the focus of what we're here to discuss today, unmet behavioral health needs. How are the systems kind of built and the incentives aligned, and how are those executed upon in terms of managing those benefits? And so what's been a challenge, I think, for many health plans today is coming out of COVID, from 2019 to date, we've seen over a 40% increase in outpatient utilization, and that trend continues. There were days not too long ago when I was at Optum when we would have been very happy and supportive of seeing an increase in outpatient utilization, because we knew that given prevalence rates, given that the size of the population in terms of membership served, that we were only scratching the surface. When thinking about the appropriate level of care and the cost associated with delivering care, providing that treatment earlier in outpatient is going to be much less from a cost standpoint than when compared to an unmet need progressing, presenting in an emergency department or an inpatient setting or in even residential. Now, the script has flipped a bit. And in earnest, I believe that many health plans were caught off guard as we came out of COVID. We've seen, and I applaud this shift in terms of just trends in the industry, an erosion of stigma. We have many more individuals willing to raise a hand and step forward and ask for help than we ever have. That's a good thing. Yet the unit economics and, frankly, the backend business models that were built around managing benefits for a behavioral health population are far out of date and out of step with where we are in America today. And so we are in this period of, I believe, of recalibration as health plans and payers alike are trying to really understand, how do we now make those unit economics work within our business model, where we're able to sell high quality benefits and access to providers that can demonstrate clinical effectiveness, deliver care efficiently and affordably, and yet seeing that it seems only to be the tip of the iceberg in terms of need. And so, they've got their hands full in terms of trying to figure out, given parity and kind of an evolution from a policy standpoint, where the field has gone. Many of the levers the payers historically relied on in terms of managing benefits and behavioral health specifically are no longer available due to mental health and substance and addiction parity law. And so they're really looking to alternative frameworks, in particular measurement-based care and value-based care.
One of the worst parts of my job, seeing practices lose revenue, not because of bad care, but because their notes didn't back it up. If you're billing insurance, you already know that your notes are your defense. So if your documentation falls short, clawbacks, appeals, and a whole lot of headaches feel inevitable. One of the best parts of my job, empowering our clients to focus on their practice, not payer back and forth. A big part of that has been discovering Blueprint, an AI assistant purpose-built for mental health care. In other words, made by therapists for the way therapists work. I've seen folks start using Blueprint to help with getting progress notes done faster, but it has turned into a game changer. Blueprint drafts compliant treatment plans, visit notes, and flags any missing clinical notes, which means fewer denials, cleaner claims, and faster revenue capture. Check the notes for the link to give Blueprint a try for free.
So as they start to look at providers within a network or a new treatment model, what are you hearing that payers are starting to really look for and value given outdated business models?
Yeah, it's a great question, Jeremy. A couple things. One, just broadly, we operate in a fee-for-service model. Our technology and kind of the backend piping and sharing of data is archaic, if not lacking altogether. And it's a challenge from a payer's vantage point to look to, and again, I'll come back to my Optum days, a network of 500,000 behavioral health providers. How on earth do you tier that network? How do you understand who's performing effective care? Especially when you're reliant, in essence, you're kind of blind and dumb to the care in your network because the only data you've got flowing is claims-based data. And so from just to really make this simple, from a payer's standpoint at the member level, so you've got an individual accessing their benefits, receiving care, let's say it's an outpatient behavioral health. And from the payer standpoint, it's a claim paid, stop. They have no idea, did that patient get better? Did they get worse? Did they drop out of care? They just can't tell. And so the big gap in terms of data available to payers today, especially when trying to wrap their arms around such a large provider network, is patient-reported outcome data. And so when we think about physical health and medical conditions, almost every medical condition, let's just start, with chronic health conditions, whether it's diabetes, you've got a vital sign. You've got hemoglobin A1C, you've got blood sugars, right? If you're looking at hypertension, you've got blood pressure. If you're looking at obesity, you've got BMI, you've got weight, you've got lots of other things. And so literally every health condition has some sort of associated lab or vital sign. But in behavioral health, we don't have that yet. And while there's been some really great advancements that are promising in terms of moving towards more biomarkers and other types of biological kind of indicators of both advancing disease or and such, until we're there and this is routine, we're highly reliant on kind of survey-based data. And so I think most are probably familiar with the PHQ-9, the Patient Health Questionnaire. It's a 9-item survey. Most people have filled this out either in a 2-question version or a 9-question version in the waiting room of primary care or perhaps for your kiddos at the pediatrician. And it's these types of data that are asking questions aligned to kind of core and ubiquitous symptoms aligned to certain conditions such as depression, anxiety, and beyond. We're reliant on these types of survey data. And when you're able to take that at the individual level, the power of using this at the clinical dyad kind of level of the system, clinicians can use this to be very informative in terms of applying clinical judgment, having this be yet just one additional data source to take action on. But as you aggregate that patient-reported outcome data up within a health system, you can unlock value at every level of the system. Above the clinical dyad, i.e. the therapist and the patient, you may have a supervisor who's overseeing a group of clinicians and being able to look at this data to see, is there difference across a small group of providers? Bringing this data into supervision, bringing in kind of a data-informed context to really case conceptualize and to unpack kind of options in terms of treatment change. At the next level up, in terms of administrators within an organization, to identify where across at the program level or as a system, are we seeing bright spots in terms of clinical effectiveness being achieved in a timely fashion, where there may be other opportunities to invest in training and development of the clinical front line when it comes to evidence-based care and the like? The next level up, you look to payers. And at the payer level, again, to aggregate this data up, to commingle that with claims-based data, all of a sudden then there's a much more holistic picture as you start to kind of look and tier that network in terms of which organizations are really achieving clinical effectiveness in terms of their outcomes, and doing so, again, with efficiency in mind in an affordable manner. And so that's really a key thing that we as an industry need to kind of prioritize and take action on. And I applaud the Kennedy Forum and other large advocacy groups really who have been championing loudly the importance of not only bringing this as a clinical practice into the practice community, but also aligning incentives and putting reimbursement.
Which is such a challenge, right? Because alternative payment models have been around for a long time, right? Even that term has been around for 20 years or more. And I think you made a really good point there about the claim. Because the architecture of a claim does nothing other than get you to claim payment or claim not payment. And there's certainly some innovation to be had on that particular process alone that probably can help inform all the layers of healthcare that you're talking about. How is Blueprint changing the game of private practice in this regard?
Yeah. So maybe just a snapshot of introduction to Blueprint. We've been around since 2019. From 2019 to about a year ago, we were a single product company solely focused on measurement-based care or measurement-informed care enablement. Meaning we leaned into this identified gap where we don't have this data that is critical and important, and better understanding what are the barriers that are really getting in the way of broader adoption and use of measurement-based care in the behavioral health practice community. And just a footnote on this, we see best numbers point to 19% of psychiatrists, 11% of psychologists, and somewhere between 3 to 5% of master's level clinicians endorse routine use of patient-reported outcomes. And so even if we're generous and say 20% of the field is doing this, that still leaves 80% of the field that is really just kind of, flying blind when it comes
Can I interrupt you on that? Real quick, sorry to interrupt. I really want to get to there. My question about that data is, are those clinicians that are endorsing measurement-based or measurement-informed care, I don't know which term you prefer, but are those the clinicians that are doing the most volume? Is there a consideration in that realm at all? Or is that all clinicians across all organization types and volume?
It's a good question. And from an academic perspective when it comes to measurement-based care, and maybe just from a terminology standpoint, for the past 20 plus years, the terminology of measurement-based care, that phrase, has been the one that has really won out in the literature. It's what the constructs and the research and everybody that's really heads down in academia trying to understand mechanisms of change and fidelity to practice and who benefits most and by how much. At the same time, from a marketing standpoint, the optics of that term aren't really great. I remember implementing measurement-based care at Kaiser within our SUD treatment settings, and somebody raised a hand and was basically saying, I don't want to do this. This feels like it's treat by numbers. I thought that was cute.
Treat by number.
There's a perception held within the kind of practice community that using the PHQ-9s of the world, not only is clinical utility of many of the tools not really felt or seen by the clinical frontline, attitudes and beliefs around what constitutes, like what are those critical ingredients that lead to change in the care process. There's a strong belief and frankly a whole body of research pointing to common factors that really highlights the critical aspects, the relational aspects of care. And so this idea of bringing in such a rote way of practicing, many clinicians take umbrage with the word based, because it implies that it's really kind of the numbers are driving care. And so you've seen more progressive organizations such as Optum, of the big ones, but other groups really embrace this terminology of measurement informed. And it kind of softens this to some degree because it never should be practiced in a way that, because the PHQ-9 was X or the G87 was Y, therefore I'm going to do this other thing. But the data is just one more signal within the care process and should always be just kind of treated as such, which with that data in hand, along with the best of clinical judgment, then you've got just more information to work off of as you approach your treatment.
When you look at the surveyed clinicians around who endorses measurement-based care, how much volume are they doing, or is that a consideration?
Yeah.
Going back to your experience at Rogers Behavioral Health, like their vote would matter a lot more than maybe somebody who's doing less volume than they're doing, or maybe somebody with less clinical quality outcomes that they're producing. So
Yeah.
when you look at that data, right, I think you said 11% of psychiatrists, or I got the data wrong, but it's a low number, right? If 20% of the
Yeah.
industry endorses measurement-based care, is that 20% doing 80% of the care or not?
Yeah, so I don't have data in hand to answer that question directly. But what I will say just observationally is that we are amongst a sea change here. I don't know, 7-9 years ago, we started to see this kind of emergence of managed service organizations, oftentimes also kind of referred to as provider aggregators. But there was a disruption in the behavioral health space where what was seen is that the vast majority of care was being delivered in a very disaggregated kind of landscape. It's the private practice down the street, it's the small group across town.
Mm-hmm.
And the challenge from the payer standpoint, of course, is it's very difficult to ultimately contract in a one-to-many fashion. Oftentimes, putting more kind of innovative contractual models or alternative payment models in line is a challenge when you're kind of contracting in a one-to-many. And so this kind of three-sided marketplace model started to evolve. So this need from the payer standpoint was at the time the number one driver in terms of why a large employer would go with an Optum versus a Blue versus a Kaiser Permanente was access. And so the problem of these early kind of MSOs and provider aggregators was we will give you turnkey access, payer, to a network of 10,000 plus behavioral health clinicians. And you can sell that access as embedded within your network through your benefit structure and the clinical products that you're selling to these large employers primarily, or of course your kind of commercial markets and beyond. But within this three-sided marketplace, the next kind of innovation was from the provider standpoint. And so in the same way that, years ago, we saw this huge jump forward in terms of financial technology, and the days of needing to, sign the back of the check and go into the bank and deposit, long gone. Now we can take a picture. You can do online banking. And so consumer technology and digital experience came into the financial sector. And similarly, the kind of ambient expectation of consumers within healthcare was that healthcare too would take this step forward and offer kind of a parity experience in terms of ease and convenience of using technology to transact, to interact, whether it's payment, scheduling, and beyond. And so what these MSOs ultimately did was they put a large amount of investment in terms of technology. And overnight, if I was a private practice clinician, so one of my biggest challenges is frankly business development. How do I build awareness enough so that I'm driving referrals and that those referrals are consistent? And the minute that I'm, done delivering care, do I have to be out there, walking the street and trying to get my name out? And so to have reliability in terms of patient flow is a real challenge, still is. And so the MSOs ultimately said, look, here's the deal. You sign up and join our network, and here's what you're going to get for it. We're going to give you, leading technologies. We'll transact all your payments with payers for you. Pain point for many. We'll give you an unlimited supply of referrals, as many patients as you want to see through us. We're going to give you a light EHR. We're going to give you telehealth solutions today. We'll give you an AI scribe. We'll have community. We'll bring together groups. And if you want to join a webinar for continuing education, we'll do the whole thing. And so you're no longer practicing alone. You're a part of this group. And the exchange was, we'll negotiate a pretty high rate of reimbursement with the major payer. And we're going to take a pretty big cut, but we're going to give you a pass through. And so that deal worked for a bit. And then the third side of this marketplace, and I'll get back to your question here, Jeremy, was really kind of consumer focused. And consumers still today, those that are seeking behavioral health care, are challenged. My friend told me about this therapist. I have no idea if they're a network. Do I go to my provider directory on the website of my payer? I called a few numbers, but nobody's taking patients. One of them's no longer alive even. It's just there's a lot of frustration, but now there was this like slick online thing. They ask me a few questions. I sign up, and all of a sudden, I've got 3 providers with their bios and beautiful pictures to choose from. And oh my gosh, I can end this whole experience with actually having in a scheduled appointment, and you'll take my credit card, and you'll take my insurance. And so this model has really won out and matured over time. Back to your question, is that kind of 20% that's endorsing, use of measurement-based care accounted for perhaps by many of these MSOs? I would hedge a bet yes. And so there's a strong incentive as care models and consolidation has occurred within behavioral health to be able to demonstrate outcomes. And so as we're competing and trying to demonstrate quality and efficiency and affordability and experience and all the things that matter to the payer, you've seen kind of a top-down incentive within the industry to invite more providers into this. But if you kind of take the shape of a provider, a provider network as a pyramid, today, what you'll find at most national payers, even regional payers, at the top, you'll have a stack of these MSOs, the Headways, the Almas, the Rulos, the Grows, the Sonderminds of the world. Below that, you'll have these like national players like Refresh and LifeStance. And then below that, as you kind of move down, you'll hit this red line. And the minute you step over that red line, all of a sudden you're back to this very disparate landscape of, onesies, twosies, small group, mid-size, but like that disaggregated kind of provider segments. And that's where we're seeing the uptake and practice of measurement-based care is really few and far between. So back, I guess, to be more direct with answering your question, above that red line, you're seeing most of the MBC activities occur. Below the red line, we haven't put the appropriate incentives nor made it easy for these practitioners to adopt and practice measurement-based care, which, coming back to Blueprint, was kind of why we existed for the first 5 years of our life.
Yeah. And so now what's next for Blueprint, right? You mentioned you were a single product system. Were implies that's no longer. So now what's next? What's on the roadmap for Blueprint, and how do you help get more people above that red line?
So candidly, selling technology that helps make measurement-based care easy to do, there's a lot of headwinds. Not too long ago, Blueprint had a lot of direct competitors. And whether it's, the Green Spaces, the Neuroflows, the Miras, the list goes on, the Owls of the world. Some were acquired, others pivoted towards collaborative care, others moved in a completely different direction in terms of risk adjustment and kind of data-oriented things. But the reason why those headwinds exist are a few, but I'll just name 2. One is back to reimbursement. You don't have my old adage, you get what you pay for in fee for service. We're not paying for it. We're not getting it. Payers need to pay if they want the data, full stop. The consistency of that payment today is really limited, and the amount is so dilute that it's not compelling enough. Every time you administer a PHQ-9 and you drop a code, it's not a life-changing event in terms of reimbursement, but given the value and just the high criticality of payers and what they need to do today, they need to put some dollars behind not only supporting clinicians to adopt the practice, but ultimately paying for it event by event. So that's one. But 2, back to it, administrative burden. And so as we looked at kind of into these barriers, sure, we have advocacy. I do my work at the APA. We do much to yell loudly into the wind, but on the top of the hill towards payers around the importance of putting dollars behind these activities. But we realize that we're actually competing with time, and time is the widget in healthcare, and in particular behavioral health. And it's really felt at the kind of individual clinician level. And so the perception within the practice community is, and I would say that the data really points to this, that over the years and coming out of COVID in particular, this wait lists have never been longer. The clinical complexity of the cases that are walking through the front door have never been higher. Average length of treatment episodes continues to extend. The amount of time that's endorsed in terms of doing non-billable administrative tasks, including clinical documentation, continues to increase, as well as trying to advocate for appropriate reimbursement when it comes to audits and or potentially battling around clawbacks and such. We saw this opportunity at this point of kind of artificial intelligence and what it can offer to build an AI scribe for mental health clinicians. And so we went heads down and quickly brought to market one of the most compliant and high functioning AI scribes that are built by clinicians for clinicians. And, our ethos really is we want to help therapists in particular, although we support prescribers, but we want them to do their life's best work. And today, while yes, measurement-based care is a core foundation to the Blueprint product offering, today we offer AI scribing. We're saving on average 7 to 10 hours of clinical documentation time per week.
Man.
With that breathing room, not only are we bringing more sanity and time with family and balance to the just experience of being a care provider today, but we're also helping them produce highly compliant and accurate clinical documentation, which supports the whole claims process and payment and reimbursement motion that is just a part of transacting with large insurance companies. But we didn't stop there. And one of the things that we learned is that there's a lot of well-meaning clinicians that want to do the right thing. And it's really hard, especially with all the competing, the tyranny of the urgent of just managing a practice. And so we've brought in a very sophisticated recommendation engine, as it were. And so we bring insights before the clinical session, and so we can ground a therapist with, here's the top 5 things that you focused on last session. Here's some considerations in terms of what you may want to focus this session on. In session guidance, we bring up AI supported data in terms of patient reported outcomes. We provide suggestions in terms of, hey, your patient was endorsing distractibility, difficulty completing tasks, and occupational challenges at work. They're naive for an ADHD screener. Consider using this one. Or your patient was endorsing thoughts of suicide. As an intervention, here's a gold star evidence-based semi-structured risk assessment. You start with question 1 and move to the end. If you ask all these questions, you know that you're not going to miss anything. Rest assured, and that you're going to be collecting the right information to come up with a safety plan. Or clinical content that's really patient-facing. And so to allow to extend the kind of clinical value beyond the end of the 50-minute psychotherapy session. So homework assignments, whether it's a CBT thought record or whatever the DBT skill that you may be working on, we bring this in through close to 1,000 pieces of clinical content to now a very robust offering. But the big news, Jeremy, a couple Fridays ago, we were actually together when the news broke, but we're building the answer to the EHR. And so Blueprint is going to be moving into a very different product category as we try to reimagine what the electronic health record is, and bringing in automation where automation should live, augmentation where clinical decision support needs to occur, and steering clear where it really should matter in terms of care delivery.
Which is amazing, because I think the last number I saw, and all you're talking about is something you mentioned earlier, but there's so much weighing down the independent private practice owner in terms of clinical documentation, time spent in operations, administration, right? And I think the last, and you might have a better number than me, but the last number I saw was close to $900 billion of waste, right? In billing and insurance cost to healthcare organizations, and there's so much room there to be saved. And I think your Lean Six Sigma background probably helps in this regard, right? I mean, it's like, where's the waste and how do you cut it out? That's a big one for sure. So I'm really excited to see what a blueprint-driven EHR does. It's a huge undertaking for sure. So how's it going since a few Fridays ago?
Yeah, it's going well. Hats off to our product and engineering teams.
Mm-hmm.
Blueprint continues to grow. We're attracting top talent. And I'm just shocked at the speed at which an organization like ours is able to move. But more importantly, going from concept and wireframe to low fidelity product to, alpha beta testing to then commercial launch, speed to market, but ensuring that we are putting the rigor and appropriate controls to make sure that we're achieving the aspirations and aims of how the product functions. I'm just shocked. And maybe I'm still, a bit jaded coming out of organizations with close to 400,000 employees that move exceptionally slow. Just as a kind of a little quip, I literally had, when I was at Kaiser or Optum for that matter, startups would go out of business within the sales cycle as we were trying to bring them on board, which kind of speaks to just how slow, back to kind of lack of calibration. But no, it's going really well. And so where we are today is understanding that the landscape is changing. AI from a technology standpoint has really been a game changer, as I think most appreciate. But if we look at these legacy systems, the vast majority were not built for behavioral health to start. They were square peg round hole, and really it was kind of augmented and adapted to, duct tape and baling wire, have it work for behavioral health, but they were really built for physical health and on the medical side. So to have a bottoms up EHR built for behavioral health providers is unique just to start. But beyond that, if we look to all of the interests for which an EHR ultimately serves, whether it's hopefully communication coordination within and amongst teams, that it becomes the legal record in terms of clinical documentation around what services occurred and the things that were said and what was done. But most importantly, it really has become the driver of the revenue cycle. And so if you kind of look to how EHRs continue to evolve forward, the sales incentive to the decision makers that are buying the EHR products, what sells best is really around revenue and revenue capture, and being able to, from a compliance and regulatory standpoint, but also from a rev cycle standpoint, make sure that all those boxes are checked. Somewhere in this equation, that the end user gets lost, the clinician. And so we're flipping this paradigm on its head. And we're starting first with the end user in mind. And in this case, the end user is mental health therapists. So
Yeah, that's amazing.
designing from the inside out, but now with a very different toolbox than the legacy incumbents, with AI on hand and with the sophistication of what Blueprint has already built. What we're building is going to be a game changer.
Yeah, and the next step would be get the data that you are able to achieve from everything you have to the insurance company so that they can end up paying the appropriate rate for what you have. So yeah, with all the talk around AI automating notes, big data platforms, and consolidation, I think it's easy for solo and group practices to feel like they're being squeezed out. What is your single biggest piece of advice for them to not just survive, but to thrive and remain independent in this new tech-driven changing landscape?
Yeah. I mean, it's really rare today to find a private practice clinician who doesn't have some touch point with one of these MSOs. Now, I think that there's exceptions abound, so we don't need to kind of debate over that. But I think what's usual today is if you have your private practice, you've got maybe cash pay, and it's somebody that was referred to you. Your 10 o'clock may be a referral from Headway. Your 11 o'clock may be a family that was referred from Alma. And so the complexity of managing a private practice today, or even a small group practice, has really increased. The expectations in terms of what payers are demanding of private practice clinicians only increase. What used to be those kind of more egregious anecdotes of I spent 3 hours on the phone fighting over a 50-minute reimbursement for psychotherapy, payment. Like that's becoming much more frequent. And so just the experience of work has really been challenged. But we're at this inflection point where what we're seeing is many of these private practice and small group owners in particular are starting to kind of get curious around some of this really novel technology. And AI scribes, I think, is just like one of the solution categories that has been such a direct value add and with very clear return of you pay X amount per month or per session as we bill. You only pay what you use, but to be able to get all your notes in one day, if not within the clinical hour, that you can trust and go to bed at night knowing that the quality of that documentation is not only compliant, but it's accurate, and that the likelihood in terms of reducing those flags in terms of review and getting paid on time is going to be there. But most importantly, that you have time back. And so whether that is to schedule another patient if you so choose, a revenue opportunity, whether it's to have dinner with your family again, whether it's to focus more on some of those quality additive activities such as measurement-based care, whether it's to finally buy that time to do that last 10 or 15%, which you always wish that you could in terms of making those calls to the teacher or doing the case management activities that's just ubiquitous in terms of what comes with being a therapist today. And it's technology is changing the way that clinicians work. And we're at this point where a lot of these EHRs, many of them are subscription-based payment models. They're only increasing payment. Clinicians feel really locked into, the simple practices of the world. And their experience of working on these platforms isn't great. And so our big bet is that we can reimagine what this technology can do, but really kind of make the right thing easy to do and make this just hum quietly and seamlessly behind kind of the scenes so you can clear your space to do what you love best, which is come back to your purpose and your why, and be the best clinician you can.
It's a great answer. Amazing. Well, thank you so much for being on the Claim Game podcast today, Dylan. We really appreciate you being here.
Thanks so much, Jeremy. It's been an honor.
Yeah. If you enjoyed today's episode of The Claim Game, please take a moment to leave us a rating and review wherever you listen to your podcasts. It really helps new listeners to find us. Make sure you never miss an episode by subscribing to The Claim Game on your favorite podcast app. Your feedback means so much to us. We want to provide valuable education about revenue cycle management. So if there's something we didn't cover in our topic that was a burning question for you, please let us know so we can try to get you the information you desire. You can find the links to all resources we mentioned in this episode in the show notes. And if you want to dive deeper into our resources, we have 2 places you can do that. First, you can go to our blog at practicesol.com/blog, where we have 8 years of educational blogs. If you want to learn more about what Practice Solutions does, reach out. We'd love to hear from you. Just go to practicesol.com to learn more and to connect with one of our awesome people on our team. Thanks for listening. We are Jeremy and Catherine Zug, and this is The Claim Game. See you at the game table next time.